מריון מיין, בבקשה.
Thank you for inviting me. It's my honest pleasure to be here. Tally's tried to kill me during the week, but she didn't manage, so I'm still here. Now, we're working on Israeli time rather than English time, and I know coffee's important. It's important to me too, so this will be a little speedy. If there's anything I say you don't understand, I'll be around for the rest of the day. When I talk about muscular dystrophy or any neuromuscular condition, I've been doing this 30 years. My original ideas came from my teachers. My methods now come from the parents and the children. I have seen probably 2,500 boys with Dushen-Bekar muscular dystrophy, and each one will teach you something different. I met a young man the other day who was totally different from any young man I'd seen before, and I'm still learning, which is a little scary. Physiotherapy and physiotherapist are not the same thing. I am not trying to teach my parents to be physiotherapists, and I'm not trying to teach my physiotherapists to be anything but someone who thinks Duchenne muscular dystrophy first instead of physiotherapy, cerebral palsy, anything else. Now, the whole point is that physiotherapy has to work for each child and each parent at each stage of the disorder. There is no point in thinking about what was happening 6 months ago or a year ago. This is now. We need to look at what the child is doing now and tailor everything. I see my boys 6 monthly. I don't treat Duchenne boys on any regular basis. They come to me for assessment, management, and then we discuss what's important with the local teams. We need to be mobile in the joints. They don't stay static. Everything changes. We need to have a functional, pain-free life. And importantly, because of treatments that are coming, I've been saying this for 10 years. Yes, in some cases we're still waiting, but treatments are around and they are changing the natural history of Duchenne. Not always in a positive way, but we need to think about how things are changing. But more importantly, the one thing I truly believe in physiotherapy for every disorder we see, this is about reducing the burden of care on parents. It's to make things better, not make things worse. If I have made life harder for the boy or the parent, I have failed in my duty. Now, firstly, we assess. We like numbers. Drug companies like numbers. There's lots of you out there. I don't appreciate numbers. I was very bad at algebra. I failed mathematics with the lowest grade anybody had ever heard of, because to me, A equals B equals C does not work. Lifting my head equals 2. Hopping equals 2. Going up and down stairs equals 2. This is not maths, this is madness. It is not as important to lose the ability to hop as it is to lose the ability to get off the floor, but they both score 2. These are just numbers, and people get hooked on numbers, and we need to move sometimes in the clinical situation, move away from that idea. But we do need to monitor change over time. We need to evaluate our interventions, and obviously we need numbers for the researchers. In my unit, we still measure power. It's not popular. It takes time. Each one of my boys gets a 1.5 hours minimum assessment so that we cover everything we need to cover. We do measure power. It tells me asymmetry. It tells me muscle imbalance. It explains why things are happening. I don't want to know what. That is easy. Parents can tell me what. I need to tell them why. I need to measure joint range. I need to measure function. I need to measure spinal posture. Mobility does not just mean walking. We are very technical at Great Ormond Street Hospital in London. We have amazing research. Every one of the drug companies here will know of the professor I work with. and we still assess gait with a pot of paint and a piece of paper and have footprints along the floor, because it tells me what I need to know about the foot posture, it's fun, and it's functional. I don't need £20,000 worth of gait analysis assessment to be told that kid's got a funny foot. I need to look at fatigue. We don't routinely do 6-minute walk test in Duchenne, we routinely do it in Becker. My problem is my 6-minute walk test is 6-minute walk away from my department. So we tend to keep it for research projects. I need to know what's going on in the child's life if I'm only seeing them every 6 months. We do not have an occupational therapist in our team, so there's many other things I need to know about. I do not treat children. I treat families. I need to know what parents are doing, whether they're lifting children up and down stairs, in and out of a bath, in and out of a car. Are there brothers and sisters? Are there 2 or 3 brothers with Duchenne? Is mum a manifesting carrier and then finds life difficult? Are there siblings with other diseases, disorders? Maybe dad's in a wheelchair, maybe grandma's in a wheelchair and lives with you as well. This is all relevant to what I can ask my parents to do. And if the family situation is such, then I need to ask school to do it, or the local community to do it. We need to live a life. We need to see how weak we are. We need to start from the beginning. Infants can have tight finger flexors, tight hips. If we don't measure them properly, we'll never know. We need to stop stretching the ITB. So for those parents who are doing it, that's one stretch you can give up because it's a piece of rope. And if you really think you're going to stretch a piece of rope, you've got the wrong piece of rope. Functional scales, there are as many as you want to find. They will not tell you every single thing that every child can do. One of the things that happened to me when I was testing a drug was a young man who had 2 brothers said to me, when I said, what is the best thing this drug has done for you? He said, I can hit my brother's back. That is not on any functional score. We need to assess spines. It's really important. Yes, many of the boys are walking into teenage and no longer get scoliosis, but there are still boys who lose ambulation at 6, 7, 8, 9, 10 who will get scoliosis. This is our 6-minute walk test. It's very impressive. The hospital built it for us. They also wanted to give us traffic lights and trees and all pretty things, but we knew you drug companies wouldn't like it, too distracting. If one thing these boys love, it's to concentrate on something that you're not asking them to concentrate on. But what is most important about families is that physiotherapy is such a tiny part of what happens every day. You may invite a different person into your house every day of the week. You may have a different appointment with a different consultant every day of the week. A consultant is not a singular. It's a neurologist, a cardiologist, a respiratory physiologist, an endocrinologist. It could be an anesthesiologist. There are any number of people who want a piece of the action. This is why physio has to be part of everyday life, manageable, sensible, and to me, fun. We know the problem is weakness. As a physiotherapist, I am not going to cure that. I do not treat the cause of the problems, I treat the results. And therefore I have to think, if I'm not treating the cause of the problem, the results are going to keep coming back unless I manage them well. If I manage joint contractures, I am only managing the tightness, not what causes the tightness. So this, unfortunately, is for life. And on top of the weakness caused by the Duchenne, we have the disuse atrophy. The thing that everybody in this room has are those muscles that don't get enough exercise. Some of you will have a lot more than others. If you think that you do not have any, go to the gym tomorrow, work 20 minutes very hard on a machine you have never used, and the day after, you will find your disuse atrophy. And it may be incredibly painful, but we need to be aware that if we do not work the good muscles in these boys, They will get weaker through nothing else than lack of use. Exercise is important, but it's boring. I lived on kibbutz for quite a long time, and would you believe the first word I learned, because I do speak some Ivrit, was masha'amem. This is what the kibbutzniks want you to learn first, because they say it so often. I do not do boring. I have a very low boredom threshold. My kids will tell you. I am like a flea on speed. If I do not do boring, I do not expect my parents to do boring, and I do not expect the kids to do boring. I am not going to give them a single exercise program with 20 exercises to be done every day or every week, or same thing day in, day out. One of the reasons we stop going to the gym is because it's boring. You've done that machine. It's no longer a big thrill. There are good exercises and there are bad exercises. We like these. Not everybody agrees that martial arts is feasible. It is. I have run with a 6th Dan black belt expert martial arts workshops for boys with Duchenne muscular dystrophy. The guys that worked the hardest were the weakest, because if you put a fighting stick in somebody's hand, it does not take a lot of movement to look pretty impressive. We would include basketball and many other things. I rarely stop children doing exercise. I don't like weights. We don't exercise to fatigue. We don't give exercise that works eccentric muscle, not because we know it damages it. We only know it damages rats and dogs for sure, and I don't treat rats and dogs, but we do know it's more fatiguing, and therefore we stay away because fatigue in the muscle is as bad as damaging it. So we avoid all these things, but we like play. The biggest problem I have with play today is play always comes attached to a screen with a battery and needs to be held in the hands to the exclusion of all other life around. We need to get these kids away from their electronic games, from mum's phone, dad's phone. I have 3-year-olds with their own phones. We want to increase stamina and endurance, not power, by regular exercise to aerobic level. Low weight, body weight is the ideal, but we use the elastic bands a lot. High repetition, fun, games, activity, sport. I do not give out exercises, but we do stretching. Oh boy, do we do stretching. We need it because contractures cause a lot of problems. How much force? You don't need to use force because actually all of those parents in the room who do the work of stretchers, you are doing your muscles a lot of good and your sons none. Our theory is the child does the exercise. When you are stretching ankles, the child is pulling up. When you are stretching hips, the child is pushing down. There is a really important reason for doing this. The brain thinks if I am trying to pull my foot up, I must relax the muscles that push it down because it's impossible if I were pulling up, if the brain was telling me to straighten while I'm trying to pull up, but the brain's telling me to do this. The brain is helping me to pull up. So if the boy thinks pull the foot up, the brain and the muscles will help. The muscle at the back relaxes and you'll get a better stretch. Easy peasy. You need to think stretching. Pull your foot up. It stops the fight, it increases the stretch, and it works the muscles you want to work. No boy should be doing his stretches with some sort of electronic equipment with them to take away the pain or the boredom. Stretches are active. There are passive stretches through positioning, but when you're doing your stretches, they should be active. They should never cause pain. The beauty for the boys, and there's not many here, so I can't say it to them, we do not stop the boys walking on their toes. They need to do it. I will never, ever listen to somebody say, walk with your heels down, walk with your heels down. They walk on their toes because they need to. It's mechanically advantageous. It means gastrocnemius is helping hamstring to act as a knee and hip extensor in the absence of muscles that should be doing it. In other words, the muscle that is most weak in Duchenne is your butt. Ladies have big butts because it helps to pick all the rubbish up off the floor and run up and down stairs to get the washing and do all the other things. Now we know this because the things the boys struggle with are going up and down the stairs and getting up off the floor. So the butt is weak. The hamstring muscle is attached to the butt. Let's go back. Can we go back a bit? Never mind. So we know that the butt is weak. The quadriceps, those muscles that straighten the knee, are weak. So when we're tired, if our knees go, we collapse. This is a fall. The boys don't go splat forwards, they go straight down. And that's because their knees collapse. So what is helping this? The hamstrings, again, are working to pull the butt back to stop it falling forwards. This is why we get the arched posture. They need to walk on their toes when they're tired and when they're weak to keep stable. So there's no point in nagging any child to walk with their heels down. Women know it's perfectly feasible to walk on a 10-centimeter heel. It's not impossible. The boys don't like it. That's a problem. But we want them to stand with their heels down. We want them to have some range past 90 because it gets them off the floor, it gets them up the stairs, and it gets them off a chair. We can't do anything with that. If you really don't want to do your stretches, fine, but then we do tell parents that we have good reasons for keep going. We know that they can appear from tiny. I've seen 2 or 3-year-olds with tight finger flexors and tight hips. I've had 3-year-olds come to me, have already had TA release because they've been called idiopathic toe walkers. They can occur in any joint on either side, but they don't get better. They only get worse with growth as your bones grow. If there's contractures and tightness, the bones can only keep growing into that contracture. We need to manage contractures as a daily activity. We do self-stretches, assisted stretches, we do lots of different things. Scoliosis is a contracture. There are lots of joints. It's basically the joints getting fixed in the wrong position, so we want to keep the spine as mobile as possible. We use a lot of serial casting. Now, that's caused some strange comments here in Israel. You don't do it. That's not an issue because actually they don't do it in the UK either. It's not very common. Let's get rid of that. We like to make the boys enjoy being in casts. All the ambulant boys have to walk in their casts. They can have their football club. They can have Christmas. We haven't worked one out for Yom Kippur. We can make walking fun. They do not have difficulty walking in plaster. We only do it for 2 weeks. I don't know if there's an orthopedic surgeon in the audience. We had an orthopedic surgeon who very kindly cast one of our boys for 5 weeks on just one leg and left 9 centimeters of disuse atrophy within that leg. The leg atrophied by 9 centimeters in 5 weeks. We use 3 plasters in 12 days or 2 plasters in 2 weeks. All the ambulant boys walk in them. We've never put a child off their feet. We don't have pain. We correct the hindfoot position, and it's a very useful, non-invasive way of gaining range. We don't like orthoses that stretch at night in bed. We believe that we give night splints, which is the blue one, at night to hold the foot in a good position. This is not about stretching. This is about being at 90 degrees rather than spending the night in plantar flexion. We give out self-stretchers. We love the one on the far left. We ask the parents to draw a picture of a bus or a lorry. We're lucky we have tall buses. We ask them to push. We teach the children from very young to do their own stretches. They're pushing the bus because it's broken down. It stretches their heels, stretches their calf muscle and their fingers. When they finish that, they go and get a picture, draw it on the wall, or draw something on the bus. We do neck stretches because we forget about necks, particularly in the older boys. We ask them to do some neck movement every time they look in a mirror, about 60, 70, 80 times a day. We ask them if they've got a tight foot, which sometimes happens with a tight ankle, to do foot stretches as well. It is very hard to stretch your own forearm. For anybody that is stretching hamstrings in their children or in their young patients, you may stop now. We've already said that we need the hamstrings working. They're one of the muscles that works the hardest. Is there anybody that's brave enough to admit that they cannot touch the floor when they're standing up without bending their knees? Anybody cannot touch the floor? I have two brave men who are brave enough to say that if they stood up and tried to touch the floor, yeah, no, I'm fine. What I wanted to show you, I didn't realize I was at the edge. What I wanted to show you was that the ability to touch the floor, how many of you can do it? How many of you can actually touch the floor when you stand up? Okay, you are not normal. This is a big problem we have, that people believe that normal is the ability to touch the floor. It is not. Normal at adult, an adult in this case, comes from around 10, 11, 12. You should not be able to touch the floor. To have effective hamstrings as an adult or even as a child, you need some degree of tightness in it to allow it to work. For those of you who have long hamstrings, the yoga experts, you have nice, flexible hamstrings. It's not that brilliant for back problems, strangely enough, but they are weaker. We want shorter hamstrings. We don't need to stretch them. We do need to stretch knees, but we don't need to stretch hamstrings. We want them short to be effective. What causes pain? Overstretching. Back pain. Pressure areas are rare in Duchenne. Pressure areas usually come from poorly fitting wheelchairs or poorly fitting orthoses, and fractures which are not uncommon. Now, if we go back to back pain, this is back to where I'm treating my parents. Many of my parents have back, neck, and shoulder pain. This is not acceptable. Pain is distressing. If you have constant back pain, it's very hard to work with your child. It's very hard to lift them up. It's very hard to do your transfers. We need to be sure that our parents are safe, are not injuring themselves, and know what they're up to. We use a lot more of these splints now in the more ambulant boys. Now, this is one of the problems we are beginning to get with older boys. In the older boys who are continuing to walk for longer, we are seeing more problems of ankle tightness and foot problems. Because although they're walking into teenage and they're still strong, they are still getting contractures. And it is really, really important that we learn to manage these feet from early. If you are going to struggle as a teenager to walk, not because you are weak, but because you have joint problems, then we have a new problem arising. We don't treat flat feet, it's a waste of time. As I say, we use a lot of serial casting. We like good positioning, something as simple as bringing knees together and legs in line in the wheelchair. Scooters are great, but they're terrible for leg posture because the cushions are really inadequate. We only go to surgery as a last resort. We're very, very careful about what we do. We like mobility, and when the boys are struggling, we try very much to encourage them to continue to walk in CAFOs. For bone health, static standing does not improve bone health. For bone health, for spine mobility, for exercise and stretching. But if a boy decides he's had enough walking, it is scary. It is a scary disease. We really need to wake up as therapists and doctors and understand how scary this is. If I am struggling to walk, I can no longer kick a ball. I cannot get up my own stairs. I have lost all these things. What am I going to lose next? How much more difficult is it going to be for me? How much more difficult is it going to be for my parents? Do not think, the boys do not think about all these things. We need to show them that we know this is scary. We know this is hard. We know there are choices being made for them, but they must be part of this decision. If they no longer want to walk, that is a perfectly acceptable decision. We cannot force them to continue. It's not us that has the fear of falling, the fear of not being able to get up off the floor, the fear of injuring ourselves. I will not have any boy forced into continuing. But if they want to give it a go, we will do it. We like gaiters. Here you use knee immobilizers, pretty much the same thing. We use them to stabilize the knees, and we keep them walking in them until they make the decision as to whether they want to go to CAFOs, which are much more expensive, sometimes requiring surgery. When all else fails, they can stand in a standing frame, but we feel it's very passive, and if their posture is worse in the standing frame, we don't like it. Not only that, but if they're very contracted, it's actually not very comfortable. Tape is the new big thing. Everybody loves a bit of tape somewhere. From sportsmen all the way down, you will see any amount of taping on the internet. Some of our East European children have a ton of it from top to bottom. It cures nothing. I do lots of taping. Sprained ankles, painful knees, painful wrists. Joints are great to tape when there is pain. They won't cure contractures, they won't build muscles, and you can't use them forever. A word of warning, heat makes tape stick better. So if you ever need your hamstrings taping as adults, because I can tape my parents too, and have, if you need your hamstrings taping all the way up to the top, don't sit on a heated car seat. You will never get it off. So despite what the evidence says, and there actually isn't an awful lot of physiotherapy evidence at all, it's no good extrapolating from CP, it's no good saying, well, this child feels this or this exercise does that. Look at your children. Look at the effect the exercise is having. Look at what's going on. Look at the family. Are they managing this? Because the management of a child with Duchenne is good and regular assessment, understanding the nature of the condition, and bog standard common sense. Physiotherapy is boring, I accept it. I've been doing it for nearly 40 years, 30 in muscles. It can be excessively boring, so we make it part of everyday life. They do their stretches when they're cleaning their teeth, before they go to bed at night, when they get up in the morning, when they're standing to watch TV in a good position, when they're standing for their Xbox, when they're sitting with their legs out straight. We know that when we stretch, it's a temporary improvement. We have to keep going. This is for life, certainly through growth. Pain makes contractures worse. Contractures make pain worse. So there's no point in making anything painful. Poor posture needs correcting, but none of you are sitting up straight. So if I said to you, lot, sit up straight, fine, you would do it for a minute, and then you'd all be slumped again. So why we expect the boys to sit up all day is beyond me. We tell them to sit up straight, to stop walking on their toes. Everything is stop. Everything is negative. Let's just find some positives. There is no such thing as a lazy child. If there's grandparents in the room, I'm afraid you are the worst at the word lazy. Lazy does not exist in children. There's frustrated, there's demotivated. I've tried and it doesn't work. Everybody does it better than me. Why should I give it a go? These children need things that they can be positive about, that they can achieve, that their brothers and sisters can't do better than they can do. So give them an activity that is just theirs. Lazy is teenage rebellion and hormones. Girls thankfully get over it. No two children and families are the same. In hundreds and hundreds of families, you need hundreds and hundreds of solutions. If you have 350 families in Israel, I have 350 physiotherapy solutions for you. And ultimately, we learn from the families and children. They are the ones that will teach us what we know. So listen to them and tailor what you want to do to them. Thank you.